Welcome, and thank you for choosing the Pennsylvania Medical Home Learning Library selection on adult ADHD in primary care, treatment recommendations for patients transitioning from pediatric care. On our webinar today is Dr. Brooke Molina and Dr. Shahari Bangalore. Dr. Brooke Molina is a professor of psychiatry and psychology who has dedicated her career to helping children and families through her clinical research activities and to helping early career scientists make the transition to the next stage of their careers. Dr. Molina earned a master's degree and PhD in clinical psychology from Arizona State University before relocating to Pittsburgh, where she completed the clinical psychology internship program at Western Psychiatric Institute and Clinic. She obtained a postdoctoral training as a postdoctoral scholar in a federally funded alcohol research training program at the University of Pittsburgh before her appointment to the Department of Psychiatry faculty in 1995. Dr. Molina is also a licensed psychologist in Pennsylvania. The focus of Dr. Molina's research interests are in the long-term course of treatment of behavioral problems, especially attention deficit hyperactivity disorder, alcoholism, and drug abuse among youth and young adults. As Director of Youth and Family Research Programs, she oversees a robust research program engaged in the study of ADHD and other disruptive behavioral disorders, as well as substance use disorders. Dr. Molina is the principal investigator of a merit award of the National Institute on Alcohol Abuse and Alcoholism, which she is studying the factors that contribute to the risk of alcohol use disorders for children with ADHD. Dr. Shahari Bangalore is an assistant professor of psychiatry at Western Psychiatric Institute and Clinic. Dr. Bangalore completed medical school at Bangalore Medical College, India, and later earned a master's degree in public health and epidemiology from University of Alabama at Birmingham. He did his initial adult psychiatry residency at SUNY Downstate University, New York, before relocating to Pittsburgh, where he completed the Child and Adolescent Psychiatry Fellowship at Western Psychiatric Institute and Clinic. He presently works as the medical director of the ADHD Across the Lifespan Clinic, the medical director of the Youth and Family Research Program, and the medical director of services for the treatment of early psychoses, the STEP Clinic at Western Psychiatric Institute and Clinic. Dr. Bangalore's research interests are on the interrelationships between substance use and psychopathology, both ADHD and psychosis. He is the recipient of the NARSAD grant studying the effects of cannabis on cortical oscillations and is a co-investigator with Dr. Molina on 2 awards from the National Institute on Drug Abuse designed to develop strategies to help primary care providers target stimulant misuse by high school and college-age youth in the community. Thank you, doctors, and please take it away.
Well, thank you for that very nice introduction. We're both delighted to be speaking with this audience today. We've been doing some very interesting work in primary care and have been discovering that quite a few pediatricians have been talking with adult primary care providers who need more information about how to diagnose and treat adult ADHD. So hopefully we'll provide you with some tips and guidance today that will be helpful. I'd like to start with just a review of what ADHD in adulthood should look like. Everyone knows most providers are quite familiar with the 3 core symptoms of ADHD listed at the top of this slide: inattention, impulsivity, and hyperactivity or restlessness. These symptoms are generally pretty easy to diagnose and recognize. Pediatricians have known them for a long time. But what do they look like in adulthood? So I'd like to point out that inattention is a frequent difficulty with keeping attention on most often tasks that are boring or repetitive. So we're not talking about difficulties with sustaining attention all the time in every circumstance. But for ADHD, we're talking about having problems with maintaining focus in situations that are just usually the ones that are not so fun and they require extra effort, such as paying bills, such as doing your taxes, doing your college homework, completing a chore that someone else has asked you to do but you're not so excited about doing it. So maybe your roommate's asking you to organize your belongings or straighten up your messes. Adults with ADHD who have problems with impulsivity, this shows up most commonly in interrupting other people, finishing their sentences for them. It also can be behaving without consideration of the consequences. So spending money impulsively, for example. There is also often a sense of internal restlessness, a pressing need to stay physically active. Not all adults will suffer from this component of ADHD or the impulsivity component, but it does often happen. In children, it's the getting out of the seat, the running around, the being more physically difficult to manage. But in adults, this often morphs into more of a sense of internal restlessness, not liking those long meetings or the long lectures in college that are the 3-hour lectures once a week. Those are rough for adults with ADHD. So those are the common symptoms, the core symptoms in adults with ADHD. Well, what goes along with it? Commonly co-occurring are difficulties with executive function deficits. And these are problems that are really often the ways in which ADHD symptoms will manifest, but we describe them a little bit differently, but they also look very much like the ADHD symptoms themselves. So difficulties with planning, with organization, prioritizing when there are all kinds of things that need to be done in a day or in the work day or the work week or in one's life, such as organizing the house or the paperwork, the mail that comes in on a daily basis. Email needs to be prioritized in how we attend to it. People with ADHD have a very difficult time handling all of this onslaught of different forms of responsibilities. Working memory, the capacity to hold in mind information that one needs in the moment to solve a problem, such as a math problem or a difficult project at work. These are almost part and parcel of ADHD. They really pretty much go hand in hand with the symptoms of ADHD. We commonly see the following comorbidities, and I'll talk more about these on another slide, but about a third of children and adolescents have learning disabilities, so this is something that does need to be attended to in the course of diagnosis and treatment. The other disorders listed there are very common. The educational and employment difficulties are the typical impairments that you see associated with ADHD. This is where ADHD rears its ugly head and what often brings people in for treatment. So in psychiatry, we use the DSM-4, and we used the DSM-4 now, since 2013, we use the DSM-5. A considerable amount of research was reviewed before revising the diagnostic criteria for ADHD. This is because we now understand that the disorder persists into adulthood, and we also understand that maybe the symptoms that we used to diagnose childhood ADHD might not be quite appropriate for diagnosing in adulthood. And that's why, for adults now, instead of requiring 6 symptoms of inattention and/or 6 symptoms of hyperactivity and impulsivity, we now require only 5 symptoms in order to diagnose. We used to require evidence of symptoms onsetting before the age of 7. Now, because many adults present for their first diagnosis, it's often hard to find evidence of those symptoms at such an early age, particularly if there aren't parents in the picture. So now we look for symptoms occurring somewhere in generally the elementary school age range. We look for several symptoms in that age range, not just one in one situation. If there was one teacher, for example, or one school where there was difficulty, but no problems at home, or vice versa, actually, that's the one that's more concerning. when there were problems at home, but school was fine. That is, at least when we're diagnosing a child, that's when we think something else might be going on. So we look for some degree of symptom pervasiveness and multiple symptoms occurring in childhood, and that is collected with a good history. In adulthood, we look for symptoms in 2 or more settings. So we're going to be looking at in the home setting when we interview. We're going to be talking about the school setting if they're in college or in some kind of training program. In the work setting, we're going to be looking for difficulty. So this is important, symptom pervasiveness. If ADHD exists only in one setting, then we should have some alarm bells going off that maybe this is something that is situation specific and not the disorder per se. ADHD is a condition that should be pervasive. It goes with the person across settings. We should be looking for that. We used to diagnose subtypes. We used to diagnose inattentive subtype, combined subtype, which was all the symptoms, and hyperactive impulsive subtype, which is a little less common. We don't see that so often. We now, instead of using the word subtype, we use the word presentation. And we do this to reflect the fact that people change a bit with age and which symptoms manifest the most and the way that their disorder presents. So we moved more to the word presentation to reflect that. And we also now allow a diagnosis of ADHD for individuals who have an autism diagnosis. We have a large number of studies now that have followed children who were carefully diagnosed with ADHD using rigorous diagnostic research criteria. And these samples have been followed into various stages of adulthood. Across the studies listed here, you can see that they are in various locations in the United States. Some samples are still ongoing. In Pittsburgh, we have the Pittsburgh ADHD Longitudinal Study. That's the Molina and Pelham project, and we're following those children now through their 30s. What's important is that this is quite a wealth of information that is ongoing. We're continuing to study the disorder into adulthood so that we can better understand what are the factors that are associated with healthy outcomes as well as impaired outcomes. And you'll see that literature continuing to develop with time. What have we learned from those studies? We have learned that there are quite a few adverse outcomes associated with the diagnosis of childhood ADHD. This is why it's important to recognize that this disorder continues, and it continues to require treatment and attention as many individuals move into adulthood. So not all children with ADHD will continue to be diagnosable. Many will. Across the studies, it's safe to say that about half of children with ADHD persist with diagnosable ADHD into early adulthood. These rates are variable. They're variable because different studies use different methods for diagnosing. They use clinical interviews, they use rating scales, they use self-report. In some studies, including ours in Pittsburgh, we use additional informant reports, such as maybe still the parents or a spouse or a roommate. And that has been helpful to get a sense of, a better sense of how many of these individuals do we truly believe continue to be diagnosable. So many continue to suffer from these symptoms, and they continue to have impairments. And you can see some of the major impairments in this list that follow the sometimes the continuing symptoms, sometimes they happen without the continuing symptoms. So education problems, job performance problems, automobile problems, court appearances, casual sex and early pregnancies, alcoholism and drug abuse. The tobacco dependence is quite dramatic. In the United States, about 19% of people are daily smokers. Across the studies, longitudinal studies of children with ADHD, we're finding approximately 40% of these children become daily smokers. And when one considers the difficulties involved with quitting and the health hazards associated with this, it's easy to understand why we're concerned about that. Is late onset ADHD real? You'll probably be hearing more about this if you haven't already. Some new studies have been coming out identifying cases in large samples where adults are diagnosable with ADHD based on the data they provided, but they weren't diagnosable as children. And this has raised quite a bit of discussion about what this is. Is it ADHD? So maybe, but there are quite a few factors to consider, and this literature is still evolving. So we're not at a point where we're comfortable with saying, yes, it's a real entity, it is truly late onset ADHD. In many of these cases, it's entirely possible that the neurodevelopmental characteristics of the disorder were in place in childhood, but because of poor recall, because of an absence of good childhood records, the disorder was simply missed. In other cases, there may have been subthreshold symptoms. This disorder exists on a continuum. It's not a you have it, you don't. You can have a little, you can have a lot, and it will express itself differently in different environments depending on the level of structure that's provided. So, for example, one can imagine a very supportive family with highly involved parents and an excellent school setting where a child, even maybe with a higher IQ, manages fine, and then moves on to college where parents are no longer there. Child is an adult who wants to be independent, and suddenly the symptoms rear their ugly head, grades fall, and he's in your office looking for help. That may have been ADHD all along. It was simply not diagnosed. There are many comorbidities that we'll talk about need to be ruled out when diagnosing ADHD. So, as a primary care practitioner seeing adults, you're going to have, of course, a variety of cases. They're all going to be different. We've grouped them into what we hope are two helpful types of cases to discuss. One is an ideal transfer from pediatric care. The other is the more challenging one. We're going to start with the easier one. So the ideal transfer, what might this patient look like? So this would be a patient who has good medical records that include childhood diagnosis and treatment. Parent and teacher ratings were collected at that childhood assessment using standardized rating scales, hopefully, but at least in that record you have good evidence that those symptoms were present in childhood, in multiple settings, that they were corroborated by teacher report, there were difficulties in school. So you feel pretty good that it was there, it was diagnosed at the age where it typically presents first, which is in elementary school. And stimulants may have been used off and on with good effect. So that's very helpful to see. You don't necessarily need to see that stimulants were consistently used throughout. But if you see that they were tried off and on and they were helpful, that's helpful information. We don't diagnose ADHD with stimulant medication. That is not a good way to do it. There is research, old research, that shows that some performance enhancement can be seen with stimulant medication in children who don't have the disorder. It's not super compelling data in terms of suggesting that stimulants should be very helpful for people without ADHD, but when we see in the record that stimulants were used, and on top of that we see good data about the symptoms being present, that's helpful information. So this patient will be presenting as an adult and will be looking for continued treatment. And you won't be seeing other red flags that, such as heavy substance abuse or an unwillingness to consider non-medicinal therapies. I'm going to talk a bit about what those non-medicinal therapies are, because we advocate that those be considered in good treatment of adult ADHD. So your option here will be to continue with the pediatric regimen. And Dr. Bangalore will talk about the medicine regimen. I'm going to talk in the next slide about the non-medicinal therapies. So there's a small but growing literature on what these treatments are for adults with ADHD, and it's helpful for you to understand them because you can have a brief discussion with your patient about them so that they can take advantage of these supports. When they're willing to do that, you can feel even more confident about your diagnosis of ADHD and treatment of this patient. So these treatments that have the supportive evidence behind them are behavioral and cognitive therapies. They emphasize the things that you see here at the top of the slide: time management, organization, planning, and thought processes, so thoughts and moods and errors in thinking that undermine one's ability to manage their condition. They can sound rather mundane. We all work on our time management and organization, but for the individual with ADHD, they do need additional supports often in order to derive strategies that are helpful to adapt to their condition. So why should you refer to these treatments? Your patient is likely to stop taking medication in the future. So it's very common for individuals on any type of psychotropic medication, and I'm sure you experience this with other forms of medication, to stop taking the medication that's prescribed. And there are multiple reasons that we hear for people doing that. But the bottom line is they may stop taking their medication. And the medication doesn't teach them the very skill set that they need to work hard on in the list above to adapt to their condition. We do know in childhood that dosage of medication can be lower with behavioral treatments. So that's one way for them to take less drug over time. And we also know that patients who put forth effort toward these behavioral strategies, it simply helps us feel better that the patient is doing whatever they can to improve their situation. And we feel better then about prescribing. So what does organization and planning look like? You may or may not choose to have these conversations, but a few brief tips here we thought might be helpful for you to have in your toolkit for when you're talking with your ADHD patient. So learning to use a calendar book. It's such a simple thing. Many of us use them either on paper or electronically, but folks with ADHD really do need these systems, and simply deciding to use a system and implement it often is not enough. They often need assistance with it. They go astray very quickly, either over-organizing or under-organizing themselves, failing to use it for a variety of reasons. So that's why it's often helpful for them to work with a therapist to get something that's titrated to just their specific needs about what works for them. Task lists are a separate strategy where it's basically a to-do list, and there are many different ways to do this. Lots of people have different ways, different strategies that work for them. We all know that task lists can get quite complicated. There are short-term to do. There's things that need to be done today. There are things that need to be done where something bad will happen, such as paying that delinquent credit card bill that a debt collector will come knocking on the door, call incessantly if it's not paid, versus something that is just much more lower on the list, like paying the magazine subscription bill. People with ADHD need help understanding how to use these task lists. Problem-solving skills, such as breaking tasks into steps and choosing a solution, even if it's less than ideal. So folks with ADHD will get caught up sometimes in these steps and get blocked from moving forward. And some support for helping them choose a solution and move forward and learning from that and knowing when to do that can be very helpful in therapy. And then, of course, many of us struggle with the bulk of mail and papers that we all have to organize in our lives, and people with ADHD particularly suffer from this. Down in the bottom of the slide, you can see some of the very nice references that are available that talk about these strategies that your patients might be interested in reviewing. And I've drawn from particularly Steve Safran's work for these slides. Another tip is for working with these patients in therapy is efforts to reduce the impact of their distractibility on their day-to-day life. So in order to do that, one strategy that they are often coached into using is breaking tasks into manageable steps. So people with ADHD are particularly prone to looking at the whole job that needs to be completed and then becoming overwhelmed, and then their attention just wanders partly because it's overwhelming. So it's helpful for them to be reminded through therapy and then to eventually develop into a habit the strategy of breaking tasks into manageable steps. There are ways to manage distraction that are listed here. They're particularly useful for boring tasks, picking a specific time to get a task done, starting with paper and pencil at one side, and then if a distractor occurs, which we all know, texting is a big one, they can choose a strategy wherein they make a note on the paper, text Julie back at 5 o'clock, and then they can set it aside and return their attention back to their task at hand. I often use this myself in my work, and it's extremely helpful. Then they can attend to that distractor, all forms of distractors. Once it's written down, they can free their mind of it and keep moving on for the time that they have picked to work. Thought processes. So it's easy to dismiss the notion that moods and feelings should be paid attention to in ADHD, but in fact, what Steve Safran talks about is that there are thought processes that get in the way of moving forward with these problem-solving, organization, and planning strategies. So thoughts such as, this is going to be so much work, or I can't do this. Feelings like I'm overwhelmed lead to procrastination. The procrastination, then, of course, we all know what that leads to. The task doesn't get done, and then that's where our impairments arise, the poor grades, the poor performance evaluations at work. All or nothing thinking errors. These are thought processes that have been historically identified in depression treatments, but they also are relevant here for ADHD. So in therapy, the therapist works with the patient to identify that they're having these thoughts and then to develop strategies for dealing with them. The therapist helps them think about their situations rationally and adaptively. So am I expecting this all to be done today? And once they realize that maybe they're expecting that and they wouldn't have expected that of somebody else, then they're able to start to break their task into smaller, manageable chunks and accomplish those small chunks and feel better about it. And that reinforces continued adapting. So I talked about the ideal transfer, talked about the non-medicinal therapies that might be discussed with your patient, either briefly yourself or referring them to a therapist. You probably also often have challenging transfer cases, and that may indeed be why you're listening to this webinar. So in these cases, these are often adults who are coming to you because they haven't been diagnosed before, or they were only just recently diagnosed. You may be concerned about this case. You may be concerned because childhood didn't show any problems. There weren't any difficulties in school. Parents were not complaining to the pediatrician. There's no sign that the parent had to put forth extra effort in order to help that child. There was no IEP in the school setting, no ratings, nothing in the record. There may be some other conditions, such as depression or anxiety, that complicate the picture. There may also be red flags, such as the ones listed below here. There may be substance abuse, risky behaviors, such as maybe trouble with the law. This patient may be requesting a very specific medication, such as Adderall. You have a young adult coming in who says, I tried my friend's Adderall and it helped me. I think I might have ADHD. Now what do you do? They may not be interested in any of those non-medicinal therapies that I just talked about. That is a little bit of a red flag. Not always, but it's something to consider. So what do you do with this patient? Well, you need to do a comprehensive assessment. That's what we're suggesting. Reviewing the symptoms, the impairments, which are the difficulties that are caused by the symptoms, and any co-occurring psychiatric problems that are presenting. We suggest a clinical interview, collection of rating scales using standardized rating scales, and we provide you one at the end of a nice reference to one at the end of our slide set. And perhaps collecting collateral information, which would be reports from either parents or other informants, such as a spouse, or collecting old records that can be tremendously helpful. Other comorbidities are important to assess. So if you're thinking about ADHD, you should also consider the possibility that there are other problems that might be masquerading as ADHD or simply complicating the picture. So depression, we know, decreases motivation. Impulsivity is common in mania, and substance abuse, we know, affects attention and particularly working memory. So all of these need to be considered in the workup, diagnostic workup. ADHD symptoms begin early, and they are generally persistent. However, the other problems that I just talked about above tend to present more in a more periodic way. So that is one way. If you take a careful history, look at the onset of the ADHD symptoms and their course, and the same approach with the other problems that are mentioned up above, that's a good way to try and sort out whether or not the ADHD symptoms preceded the onset and periodic occurrence of the problems above. They can all happen together, but it's helpful to get a good time course. And if it becomes just too complicated and too hard, then that may be a time when you want to refer out. In this slide, you can simply see how common it is that patients will present with these other problems. So notice the frequency of mood and anxiety. Substance use disorder varies with the type of drug and how severe it is. an intermittent explosive disorder, we do have mood or anger problems in a number of these patients. So the next slide is about medication, and this is where I'd like to hand the presentation over to Dr. Bangalore.
Thank you, Brooke, for the overview as well as the non-medicational therapies. So medications for adult ADHD are very similar to the ones that are used in children. So in some ways, in the world of child psychiatry, most medications are approved for adults and are used in children without an approval. However, in the case of ADHD, it's the other way around. Most of these medicines get approved for children and then they are used in adults. So the safety and efficacy have already been looked at in children, and so it's thought to be relatively safe in adults as we move ahead. So medications target the ADHD symptoms. So the key point here is we are focusing on the symptoms as the core symptoms of inattention, impulsivity, hyperactivity, as Dr. Molina talked about. So the medications are more focused on acting on these symptoms, which are to be monitored using the rating scales. And clinical effectiveness is sometimes less in adults as compared to children who may be more sensitive to these medications. And Dr. Molina just talked about the psychiatric comorbidities. Many times, most of the adults who present to our clinic for treatment have multiple comorbidities, most commonly anxiety and depression, which have to be kind of considered as the medicines. It feels as if their ADHD is not improving, whereas it may be a comorbidity that needs to be addressed. Now, most of the medications which are taken by children are usually kind of administered by their parents, whereas in adults they have, or college age teenagers, college age kids and adults, they are in control of their medication, so they tend to take it more on a PRN basis based on their classes, on the work schedules, and that is something else that has to be kept in mind. So what are the basics of this medication management, either in children or adults with ADHD? So the overall broad picture is one of stimulants and non-stimulants. So we have the stimulants, which are the most commonly prescribed medications for ADHD. And when it comes to adolescents and adults, the long-acting medications are the ones that are typically prescribed. However, the question that the adults are going to ask you are, can we get more of the short-acting preparations rather than the long-acting preparations? And we'll discuss this a little bit more later on. The non-stimulants are atomoxetine hydrochloride or Strattera and the alpha-2 agonists. So whenever there is somebody who comes to my practice and I'm initiating medications, I open up with a discussion of both stimulants and non-stimulants and lay everything out on the table. So that way there's a clear understanding that there are different medications, and then we may make a selection based on the history that they have provided and what information we have at that point of time. Some of the basic principles, let's focus on some stimulants. Some of the basic principles with respect to stimulants as well as any medication is to provide a lot of psychoeducation about the medication options, talking about different types of medications, namely the methylphenidate and amphetamine complexes. And then going on with FDA-informed guidelines. As I mentioned earlier, the dose of the stimulant is again based on the symptoms, and with an adult, given their capacity to tolerate side effects, and we are not so much worried about weight issues, in adults, one can maximize the dose of the stimulant before switching on to a different medication. Now, in terms of individuals who have difficulty in all their symptoms being controlled with one stimulant, one could also use adjunctive non-stimulants namely the alpha-2 agonists, which are the most frequently utilized in children, adolescents, and adults, along with stimulant medications before we move on to other psychotropic medications. Example, in an individual who has ADHD as well as some sleep disturbances, one sees that there's a common combination is one of a stimulant as well as an alpha-2 agonist, rather than a separate medication for a sleep disorder itself. So moving on with the guidelines for the basic principles, what we tend to do in medications with stimulant management is we monitor the heart rate. We want to get a good indication of their cardiac status, and monitoring their vital signs is almost an important part of the evaluation. And we do this because the stimulants are known to increase the blood pressure and the heart rate by a small amount, although in longitudinal studies it has been shown that there is a reasonable amount of safety in spite of use of the stimulants. We monitor for tolerance with respect to the medication, so there may be adults who may be coming back, returning, stating that this medication is not working well, and so we increase the dose, and then at some point of time, if it appears as if you have already maximized the dose, and then they continue to need more or higher doses or request higher doses, then that may be a potential time when one could consider a referral to psychiatrists from the primary care practice. And in terms of dosing of these medications, an average ballpark in terms of milligram per kilogram, mostly used in children and adolescents, is for the methylphenidate and atomoxetine, that's about a milligram per kilogram of body weight, and for amphetamines, about 0.5 milligram per kilogram. Now, this is kind of important to keep in mind in the teenage years, in the early childhood/teenage years, when we are making transitions, because there may be increased pressure in school. There may be families who will want to do more and more medication just to get that child or teen right in doing their schoolwork as well as attending to homework, and these days there are various activities. So one has to kind of balance this out about the medication doses with respect to the functioning of the individual. Now, the commonly prescribed medications by primary care physicians are the methylphenidate extended release and the amphetamine extended release salts, the mixed salts. And the dose range which are typically used for the methylphenidate, example, Concerta, is between 18 and 72 milligrams. And for a medication like Adderall XR, goes between 5 and 40 milligrams. Most of these medications are combinations of immediate release and delayed release beads, and they are manufactured and kind of marketed so there are numerous methylphenidate and amphetamine salts with varying combinations of the immediate and delayed release beads that have been marketed, and so one can use a long-acting version of any of these. Now, when it comes to adolescents and adults whom we are diagnosing for the first time and then are using medications, it probably is a good idea to use medications with the least abuse potential. A few of these examples may be Concerta with the OROS technology. The idea behind this being that the capsule is in such a form that it is hydrophilic. Once the medication is taken in, the water gets absorbed, and there's a small piston-like mechanism within the capsule which pushes the medication out gradually. And so if this capsule is crushed or cut, then it becomes like a short-acting medication and loses much of its, and becomes like a glob and loses much of its effect. So this has a relatively less abuse potential as compared to say a medication like amphetamine XR, mixed salt, or Adderall. The other medication that is seen on your slide is Vyvanse or lisdexamfetamine mesylate, which is a prodrug which has to be taken in or swallowed, and then an enzyme lysine breaks this down to its active moiety, the dextroamphetamine salts. So again, more and more medications and the formulations are coming out in such a manner to help prevent or to have least substance use potential, and those may be the ones used in adolescents and adults. So on this slide, you see an ADHD medication guide, and if you go to this particular slide, it gives you a good idea of all the medications at present time in their doses, as well as the indications / the approval, the FDA indicated approvals. And so I should kind of give thanks to Cohen Children's Medical Center, Northwell Health, which has been updating this, and this was last updated August 2016. So this is a relatively comprehensive list of most of the medications, which you can kind of have a printout and keep it for reference, and look at the various types of methylphenidate and amphetamine derivatives, the doses and the different mechanisms, the liquid forms, the capsule forms, and others ways that these stimulants and other ADHD medications are available. So cardiovascular monitoring. So moving on to some relevant pieces that have to be done when we start our patients on stimulant medications. Now, as I mentioned earlier, the ADHD medications require vital signs monitoring. Now, the cardiovascular monitoring came into a big focus in 2007 when the American Heart Association put out the guidelines saying every patient on stimulant medications needs an EKG. This was relatively quickly kind of withdrawn after ACAP came out with the idea that every individual on a stimulant medication does not need an EKG. And now, as you see on the slide, we consider an EKG and referral to cardiologist if there's a family history of arrhythmias, if there are structural cardiac defects, if there is any family history of sudden cardiac death or sudden death below age 45, or individuals are on multiple medications which may affect the QTC interval. If it is above 500, then one has to be concerned about this, and then you kind of take into consideration what medication may be affecting the QTC interval. Now, for children who are adopted and where you do not have a good family history, it may also be a good idea to get an EKG done. So on the one hand, it's better to be safe than sorry. So if your clinical instinct suggests that this individual warrants an EKG, you could always do an EKG. And if there's any other issues that are going on, especially in primary care, if you see many individuals with other medical comorbidities, then they may get further cardiology workup if necessary. So moving from stimulants to non-stimulants for ADHD, among the non-stimulants for ADHD, the one that has been used for a long period of time is atomoxetine hydrochloride or Strattera, and then there are the alpha-2 agonists, the guanfacine, which is also available in long-acting form as Intuniv, and the clonidine, which is also available in the long-acting form as Capro. So why do we use non-stimulants for ADHD? So some of the reasons why we go with non-stimulants are the stimulants are, as we all know, scheduled to medication with potential for abuse liability, diversion, and medical legal concerns. And especially with an adult, most of the folks in primary care practice Dr. Molina discussed, there may be few people who may be coming in without a prior history of ADHD, and also the individual who may have some high risk potential. And so there we consider non-stimulants as a potential alternative to stimulants to treat ADHD. And there are many individuals who do not adequately respond or cannot tolerate stimulant treatment, or individuals with comorbidities where addition of a stimulant may worsen some of the anxiety symptoms or may cause more irritability. So in that case, one could consider a non-stimulant. For some other individuals, they may have a side effect profile which may impact their sleep. Although the dose of the stimulant may be low, it may still impact sleep or worsen mood or anxiety, which in turn may lead to the consideration of a non-stimulant. And finally, if there are any concerns about cardiovascular effects, then one could also consider a non-stimulant in that case. So some information about Strattera, which is one of the main non-stimulants that has been approved for ADHD. This is one of the first choice among non-stimulants. For folks who have used SSRIs, Strattera works similar to, the time duration is similar to that of an SSRI or an antidepressant, in the sense that the medication has to be started and it will take a couple of weeks before the full effect of the medication is noted. It also has a similar black box warning, similar to an antidepressant, which is increase in suicidal thoughts, mostly in adolescents and young adults, and probably is a good idea to mention that to the patients. It is important over a period of time to monitor liver functions, and then to kind of keep in mind if there is co-occurring alcohol use, because both go through the liver, and it's important to monitor liver functions because of that reason. And for some individuals, they may report that Strattera may have some sedative effects, and so given that Strattera is a non-stimulant, can be taken once a day, whether morning or night, and just has to be taken continuously. The other important piece about a non-stimulant like Strattera is that it has to be taken daily, as compared to a stimulant where there may be periods of time when you can give breaks. Whereas Strattera, if there is, say, a long vacation like a Christmas break, and if the individual does not take it for like 8 to 10 days, then there may have to be like a revamping of effect and re-increase or reinitiation of medication, because the effect may be gone after 8 to 10 days, whereas the stimulant will work the same day. So in terms of weight-based dosing, it is again about 1 to 1.5 milligram per kilogram, as I mentioned earlier. Moving on to alpha-2 agonists, as I mentioned, there are the two, the guanfacine and clonidine, which are also available in long-acting forms at present time, and both of them have been approved for the treatment of ADHD, both as standalone medications, as a monotherapy, as well as add-on to stimulant medications. Now, clonidine especially has been used in substance use disorders in the past, and so that can potentially be a medication where an individual has some mild substance use and ADHD, who's struggling with both. Now, these medications, guanfacine has been shown to have efficacy in tic disorders. So there are individuals with ADHD and tic disorders where, again, guanfacine may make a natural choice for some of these individuals. Now, the recent research states that tics are not caused by stimulant medications, but could be co-occurring, and there are tics seen more during childhood, and by adulthood, usually the tics kind of go down in frequency, and so one can kind of use a combination of these medications to help these individuals. And the side effects of these medications, the alpha-2 agonist, as noted on the screen, is hypotension, bradycardia, fatigue, sedation. So the cardiac monitoring again comes into play here, clearly, as most most of the medications for ADHD seem to have an effect on the cardiac status, whether it is affecting the heart rate or the blood pressure. Now, the dosing of these medications, with clonidine, the dose range is between 0.5. So this is, we are all talking about in the 0.5 to 3 milligram doses. Can be usually initiated at night, as clonidine is very sedative in its effects. It is started at night and then if necessary extended to BID or TID dosing. The guanfacine is less sedative in its properties, and the dose range there is between 1 and 4 milligrams. Again, morning BID or TID dosing, and usually guanfacine is started as an evening dose and then changed to a BID dose, and finally it is converted to a long-acting Capway or a long-acting guanfacine dose. Now, some of the other medications that are used to treat ADHD are seen on the slide, and I'm going to briefly go over them. Wellbutrin or bupropion is commonly used, especially in teenagers, where the symptoms of ADHD and depression may be comorbid, or where it may be slightly confusing. So an individual with childhood ADHD on early onset as a kid now is a teenager, and you have increased the dose to an appropriate dose, and they are still struggling with some mood issues, and you're thinking what to do next, what is the next strategy in medication management. Wellbutrin will help with some of the symptoms of mild depression, irritability, and mood symptoms, as well as help with some of the ADHD symptoms. So that is probably a good choice then. Venlafaxine also has been noted to have some effects in helping with symptoms of ADHD as an adjunct. Modafinil or Provigil is another medication which is approved for narcolepsy and sleep disorders. So typically for this medication, one would get a sleep study or have a sleep specialist evaluate the patient before they are started on modafinil or Provigil. Now, the tricyclic antidepressants are not used as much to treat ADHD per se, but sometimes in adjunct to help with sleep or enuresis are used as medications in the treatment of ADHD. So none of the above medicines are FDA approved, and we kind of dose them as clinically necessary, and there's a wide range of these doses. Now, in summary, when we have an adolescent adult in our clinic for the treatment of ADHD, the strategy is as follows. So if there are no high-risk factors that are noted, typically we will go with any stimulant, usually either a methylphenidate or an amphetamine salt, for the treatment of ADHD, and then we optimize the dose to address symptom control and to get the best functioning possible based on the problems that they have presented with. Now, after this, if they report of side effects or problems or inadequate symptom control, we move to a different stimulant which is not used in the first phase. So if we have used a methylphenidate, we transition them to an amphetamine salt, or vice versa. Now, after a trial of 2 stimulants at adequate doses, if they don't seem to work well and side effects seem to persist, then we move on to atomoxetine and see if the benefit of atomoxetine in such a case. Now, there have been a few studies looking at the effect or the combination of stimulants and atomoxetine, and usually kind of around this stage in the primary care practice, we are also thinking of getting a consultation to see if there's anything else that could be done. The other medications that I talked about, the bupropion, the SNRIs, the guanfacine and the clonidine, and we are moving into combination of meds now. And when we move into combination of meds and adults with more and more comorbidities, that is probably a good time to get a consultation to see if there's anything else that needs to be done to address the symptoms of ADHD. So at this stage, we as physicians and in primary care practices, I understand the pressure of having to see patients relatively quickly. And one of the things that we all do, including myself, whenever I see a patient, is to write a script, a 30-day script, and then hand it to the patient and maybe provide a few refills. Now, we are of the assumption, especially because they are stimulants and Schedule II medications, that patients tend to take this on a regular basis. However, what we know from many research studies is that stimulant adherence is as poor or as bad as for other chronic illnesses, and many patients do not take this on a regular basis, and they take it usually about 4 or 5 days a week and then do not take it on weekends. Or they may take it more frequently when they have a task on hand that they have to attend to. And this is, as I mentioned, more true in college age and adults rather than in children and adolescents. So as you see the checklist for improving adherence, one of the important things to do is to educate the patient about anticipated results of this medication, the benefits, and then the potential long-term need for medication intervention. Dr. Molina spoke about many strategies which are non-medication related to be used. So some of those strategies will work only if they are practiced on a regular basis. In a similar manner, somebody who's taking a medication will be doing well and maybe following some of these practices. And so it is a good idea to have both hand in hand going on for a period of time, so that the individual does well in whatever they plan. So whatever they present you with as a goal, to monitor that. And also to educate them that this is not something that may go away very quickly, and that they have to keep up with this on a regular basis for a long time. So early in treatment, it is probably a good idea to provide frequent follow-up and to optimize the dose to a place where they're functioning well, and to identify and treat the comorbid conditions so that they do not struggle thinking that something else is going on and that their ADHD is not well addressed or treated. So what do we do in a typical follow-up schedule and referral? So in patients with minimal risk factors, somebody who you know well for a period of time, where you have kind of had rating scales, you have old medical records, where the diagnosis of ADHD is clear, it is very typical to see a patient, give them a script, and then bring them back once in 3 months. And the typical style is to write a script for 30 days, and then we date the second 2 scripts, the post-dated scripts as of today, and then I write below the script saying, please do not fill till such and such a date of next month, and then the subsequent month. So that way, patients are not filling all these medicines at once or going to different pharmacies, so you're also minimizing relative risk, as well as you are giving them the responsibility that they're able to get their medications as necessary, and there is a good rapport and trust between you and the patient. Now, when they come back, as I talked to you about patients not taking their medicines on a regular basis, it's probably a good idea to ask your patient, how many days in a week do you take your medication? And if they say 4 days out of the week, then probably you do a quick calculation if you provided them for 3 months, saying, oh, 20 days per month times 3, 60 days. So do you have any unfilled medication, or do you have a script which is yet to be filled? And if they say so, if they say yes, then this is a good time to give 2 scripts instead of 3 scripts for the next 3 months. So you're minimizing the amount of medication that is being unused or misused or abused or all of the above. Now, in patients with multiple risk factors, it's probably a good idea to monitor them more frequently, to bring them back to the clinic. And I'll talk a little bit more about potential substance use issues and medications in a little bit. and also to consider referral to your colleagues in the Department of Psychiatry or Psychology. And many times when there are many comorbidities, we send them for a neuropsychological evaluation. And I have had patients present to me stating that they have ADHD, they're convinced that they have ADHD, and they're already on a stimulant medication from somewhere else, and they're also on a bunch of different medications, 4 or 5 medications, some benzos and others. And unfortunately, as I go through their history and review their history, I'm not convinced. So the important aspect is, if you're not convinced, you do not have to feel compelled to write the medication and send them away. You can send them to a neuropsych eval and say, well, I do not want to initiate you on the medication. We may get some workup done. And then the workup sometimes reveals that they may not have ADHD but have anxiety and personality issues. And so that there ends the story there. So it's a very useful tool in certain individuals. So moving on to substance use and ADHD, what are some of the things that we can do to address this challenge, which is an increasing challenge these days? Typically, use of non-stimulants or long-acting preparations. So as you have laid out the medication options, both medication stimulants and non-stimulants, you already have a leg in to state that, having reviewed your history, I think at this point of time, potentially a non-stimulant may be the best option. And then if your patient says, oh, I did try my buddy's Adderall and that worked the best, so there is your red flag again, saying, hey, you may have tried that, but we are here to treat your ADHD, and so I'm not comfortable, given your history, in prescribing a short-acting medication. Bringing patients frequently back, kind of seeing them on a more regular basis, keeping track of the medications that you are kind of prescribing to them, communicating with the pharmacist. Once in a while, I do pick up the phone and directly call the pharmacist to see when was the last time they filled their medications and has there been any doctor shopping going on. Having a policy where you are able to obtain random drug screens, urine toxes, if necessary. So having like a contract early on saying, as a patient, at any point of time, if there is concern, you may be subjected to a random urine drug screen / if you need to do cardiac monitoring to make sure you're safe, you may have to get an EKG. Emphasizing to patients to take their medicines regularly, then on a PRN basis, as well as discussing safe storage of medication, that they don't let their medicines lay around in the house or in a dorm, especially if they're college-age students. And then having a policy that they're not calling you frequently for lost medications, or the standard example of my dog ate my script, or it was lost on the bus or some other place. So making sure that there are some policies in place which will help you kind of have a good relationship with the patient who wants treatment for ADHD, but at the same time not having to struggle with the challenges of having kind of continuing treatment for a patient with a lot of substance use, and kind of then struggling how to deal with this patient at a later time. So at this point of time, I would like to kind of invite Dr. Molina back to discuss the sample case. And thank you.
All right, thank you, Dr. Bangalore. So a few extra slides here at the end to walk you through a case example, how to organize it. So one common case that we've heard about are the college students, and many of you may have seen these patients. So the case that we present here is a 19-year-old college student. We'll make her a female. She complains of attention problems and poor grades in college. She tried Concerta once with her pediatrician, once or twice, but she never followed through. She likes beer, and she smokes marijuana a few times a week. So what do you do with her? Well, what we suggest in the first appointment is that you discuss her symptoms and her impairment. So have have a list in your head of a standard set of questions where you will ask about the symptoms. So you ask her about problems with paying attention, careless mistakes, accuracy, not being good with detailed work, etc. When did she first notice these problems? Has she received any treatments at all for these difficulties, traditional or non-traditional? So you'll hear all kinds of stories, I'm sure, as you already have, but she may have been taking supplements in the hope of helping her symptoms. Her parents may have taken her to a therapist to see that therapist directly to help her, as opposed to the more evidence-based type of treatment, which is to work with the parents and to do parent training. Did she have any extra structure at school or at home? Did her parents have to, typically the mother, monitor her homework completion during her school years? How often did the teacher send home notes that she was having difficulty completing her assignments? Did the teacher ever call to say that she didn't seem to be performing up to her intellectual capacity? How many teachers made those kinds of complaints in childhood? These are the kinds of questions that will help you get at whether or not there were hidden, if you will, symptoms of ADHD that were simply undiagnosed. You want to ask about symptoms of mood problems, symptoms of nervousness or anxiety. Of course, we've talked quite a bit about substance abuse. The National Institute on Drug Abuse and the National Institute on Alcohol Abuse and Alcoholism both have some nice screeners available on their websites that you can use to have in your office to assess these problems. You want to ask if there are any problems with getting in trouble as a child, getting in trouble at school, getting in trouble with your parents, and then, of course, any troubles with the law, suspensions or expulsions from school. It's a good idea to ask an open-ended question. What have you tried so far to help with these problems? This will give you a sense of how long they have been going on and the degree to which the patient has really thought about this over time. Then you, of course, want to assess the risk factors for stimulant misuse, and we've talked a little bit about those. Dr. Bangalore mentioned the patient who specifically says, well, I tried my friend's Adderall and it helped, and so that's what I want. Well, of course, that's a red flag. So are you going to be handing over a prescription for a stimulant medication at that first appointment? We encourage you to resist the temptation to do that. As primary care practitioners, we know you feel compelled to help right off the bat, but you'll have to, of course, use your judgment with each case. But what we would like to encourage you to do is if you don't feel confident at that first visit that this is absolutely ADHD, then we encourage you to take a next step here before you move to medication. So we provide a link at the end to a standard ADHD rating scale that you can keep on hand at your office and hand that to your patient and ask your patient to bring it back for review at the next appointment. You might, depending on the case, try to collect collateral report of symptoms and impairment. So one thing that I've done in the past, and Dr. Bangalore has also used with his patients, is to ask that patient to do a little bit of detective work into their historical records. So go back, this is for this college student, go back and ask mom, are there report cards that can be pulled out that show evidence of underperformance or comments in the teacher comment section that showed periodically that teachers said is not working up to capacity? So those kinds of things are very helpful and really increase your confidence in the diagnosis of ADHD for patients where it's a questionable situation. That marijuana use, you're going to want to know how truly how often marijuana is being used and consider a discussion about that. There are physicians who will refuse to prescribe a stimulant when marijuana is being used on a regular basis, and sometimes that's not an unreasonable thing to do. We do know that marijuana has an effect on working memory. We've had enough studies to feel confident about that. We don't know that it's permanently changed, but we know that when marijuana is being used on a regular basis, working memory decreases. And that will definitely have an impact on academic performance in college. So we have seen practitioners basically put it to the patient, you have to pick one drug. Do you want to use the drug that I'm going to prescribe to help you with your ADHD, or do you want to use the marijuana? They work at cross purposes here. So that's not an unreasonable choice to give your patient. The discussion about the non-medicinal approaches can be very helpful, particularly for a case like this. All colleges now have tutoring or writing or academic centers available to their students. Your student who suspects ADHD and wants medication should absolutely be taking advantage of those supports. So what are they doing in order to cope with their symptoms? Medication is not going to remove those symptoms for the rest of their life. They're going to have those symptoms most likely throughout their life. And once they graduate from college, they will then have a job that is befitting a college degree, that will most likely have responsibilities that are going to be taxing. So they're going to need skills in order to cope and in order to choose the right environment to work and in order to maximize their productivity. Having the wherewithal to go develop those skills, in addition to taking medication, is a good sign that this is a patient who could benefit from a comprehensive treatment approach. So at that second appointment, this is when you can review the rating scales and of the symptoms. You can discuss them in detail. You can talk about the impairments, the very specific impairments that are being caused by those symptoms. A patient who's truly suffering from ADHD will be able to give you very good, detailed examples of the ways in which these symptoms are impairing in multiple settings. If you are suspicious, of course, that this is, may or may not be ADHD, it's not unreasonable to include a parent in some capacity. And that's up to you and your judgment in the given situation, but it can be helpful. Or a good friend, a roommate, a spouse. This is a time to discuss any non-medicinal approaches that you have recommended. Did they follow through? So you might consider medication in this case. If the symptoms clearly had the childhood onset, they've been causing impairment, they're continuing despite the patient attempting the non-medicinal supports, and their substance use is not causing significant impairment. You might consider the non-stimulant, as Dr. Bangalore mentioned, based on their level of substance use. You should definitely discuss expectations for continued monitoring. As he mentioned, he had a nice discussion about that. This is obviously not just a prescribe and go away. It's a Schedule II controlled substance, and they need to understand that we will continue to have regular discussions about the efficacy of this medication for your condition in order to continue the treatment. So I want to know how you're doing. Is it helping? And I will want to know the ways in which this medication is helping you, how your symptoms are, and in what ways your symptoms continue to affect you. And you'll want to encourage continued support for this patient and discuss that given that these symptoms are present in adulthood for this person, they are most likely going to persist for the rest of their lives. So this is something they need to wrap their heads around in terms of treatment consistently over time. Planning for college. So you may have a late adolescent, you may have a young adult who is either planning to go to college, or is planning a college change, or is planning a move to college somewhere. And these can be a little complicated, so we have a slide to hopefully help out a little bit with this. It's really important to try to discuss management of ADHD as far in advance as possible. I'm sure what happens is you get plenty of patients who are leaving next week for college and they need a prescription. Well, try to avoid that if you can. If you've been carrying this patient and ADHD has been in the picture, try to start this discussion, and this is at the end of the slide, try to discuss this a year before. I know that sounds very long, but you're going to want to put some homework on your patient and not put all the pressure on you to be reactive to their treatment needs at the last minute. So by beginning the discussion early, you handle this in a more planful way, and you coach your patient that way to be more planful about their own care. So you'll want to ask your patient to go ahead and check in with their school policy about ADHD-related accommodations. What kind of paperwork are they going to require? What help do they provide? You'll want to know how often your patient comes home. So the distance where they're traveling to is going to affect whether or not you're going to be able to continue to provide those prescriptions, or whether or not you're going to want to support them in finding their health care elsewhere. So let's say, for example, if at least they'll be coming home once every 3 months, then you can planfully agree on regular office visits and how that's going to happen and how the patient's going to remember for that to happen. If it's less than every 3 months, so let's say they're going quite far away, then you want to encourage that patient to go ahead and call student health at the college and get some names of recommended providers, and you may or may not be able to help them do that. But clearly what you're doing is putting some responsibility in your patient's hands, so you don't end up in an awkward situation feeling compelled to write a prescription for a patient you haven't seen as frequently as you need to for a Schedule II controlled substance. When should you refer out? Dr. Bangalore mentioned this, so I don't need to spend much time on it, but when symptoms are still impairing after 2 to 3 trials of FDA-recommended stims and a non-stimulant with adequate dosing, they're still having problems despite what you think is reasonable medication management. You can see the problems that are listed. They're having sleep difficulties or multiple comorbidities and substance use. This is a point, obviously, when we would encourage you to seek assistance from psychiatric care and or a psychologist to help with these complications. So we've mentioned a couple resources. We'd like to list a few here for you. We hope that the presentation's been helpful. This is a new area for many of you, so these links might be helpful. One is to the symptom checklist that we mentioned, the Adult ADHD Self-Report Scale. It can also be used for other informants to report. There's a really short version of it that can be used as a screener. And then there is a relatively new society, APSARD, American Professional Society of ADHD and Related Disorders. It's a very nice meeting that happens once a year with high-quality presentations, and their website is very well developed with nice continuing education material that you might find helpful. And then below are 2 societies, that CHAD and ADDA, that patients can click onto. They can become members. There's lots of very helpful material there. And then, of course, the American Academy of Child and Adolescent Psychiatry has some fact sheets available for families if they would like to go to that website. So that's the end of our presentation, and at this point I'm going to turn it back over to Carol because there may be some questions.
Thank you, Drs. Molina and Bangalore, for sharing your expertise and knowledge on adult ADHD in primary care. If there are any questions, please feel free to reach out to the Pennsylvania chapter of the American Academy of Peds Medical Home Program at PA Medical Home at aap.org. Thank you.